now we're going to move on to the final portion, which is another high yield area, which is GI oncology. And so I'll be presenting that. So we're going to do some GI oncology questions here. So the first question, a 58-year-old man presents with epigastric pain and melanoma. He had an EGD, which showed a large gastric ulcer, and biopsy showed adenocarcinoma. He underwent EUS, CT, and PET scan staging, which reveal a clinical T3N1 disease without evidence of distant metastases. He has no other medical comorbidities and is otherwise a fit surgical candidate. Which of the following is the most appropriate management? A, surgery followed by adjuvant nivolumab. B, chemoradiotherapy with carboplatin and paclitaxel followed by surgery. C, definitive chemoradiotherapy with FOLFOX without surgery. D, neoadjuvant FLOT surgery followed by adjuvant FLOT. And E, neoadjuvant ECX surgery followed by adjuvant ECX. So basically, this question is asking about how to manage a T3N1 gastric adenocarcinoma, so locally advanced gastric cancer. So the correct answer is D, neoadjuvant FLOT surgery followed by adjuvant FLOT. So for locally advanced gastric cancer, perioperative chemotherapy is the way to go. And the key trial you want to know is the FLOT 4 AIO study, which established FLOT as the regimen to use during perioperative chemotherapy. So answer A, which is surgery followed by nivolumab, is not correct because adjuvant nivolumab is only indicated for patients who had esophageal or GE junction cancers who have gotten neoadjuvant chemoradiation, who at the time of surgery was found to have pathologic residual disease, meaning they got neoadjuvant carbotaxol RT, they went to surgery, and then they didn't have a complete response. So those are the patients who get adjuvant nivolumab, but it's not indicated for perioperative therapy with gastric cancer. Answer B, carbotaxol radiation, is also incorrect. So this is the cross regimen for neoadjuvant therapy. So it's most appropriate for esophageal cancers, but not for gastric cancer. Answer C, definitive chemoradiation with FOLFOX would only be appropriate for patients who are otherwise unfit for surgery or have unresectable tumors. But this patient in our question is a young and fit patient with no medical comorbidities, and therefore the preferred answer is surgery with perioperative chemotherapy. And finally, answer E, which is perioperative ECX, is incorrect because the FLOT4 AIO study showed that FLOT was superior to the ECX regimen. So the correct answer is perioperative FLOT. Second question. So a 69-year-old woman presents with metastatic HER2 amplified gastric adenocarcinoma, began first-line therapy with FOLFOX plus trastuzumab. After 6 months of therapy, restaging scan revealed multiple new liver lesions consistent with disease progression. Which of the following is the most appropriate next line of therapy? Is it A, FOLFIRI plus trastuzumab, B, paclitaxel, C, trastuzumab deruxtecan, D, adotrastuzumab emtansine, or E, lapatinib? So this question is asking about second-line therapy for HER2 positive metastatic gastric cancer. And so question A asks if there's any benefit for continuing the trastuzumab if they progress on a first-line trastuzumab-containing regimen. Question B is should they then switch to standard chemotherapy? And then choices C, D, and E are testing to see if you know the data for the other HER2 targeted agents. So the correct answer is C, trastuzumab deruxtecan. So answer A, so trastuzumab beyond progression, is incorrect because there are studies, the TAC study that showed that there's no benefit from continuing trastuzumab beyond progression on an initial trastuzumab containing regimen. Answer B, which is paclitaxel alone, is incorrect because this was the control arm for the Destiny Gastric 01 study that showed that trastuzumab deruxtecan led to significantly improved survival and response rate over paclitaxel chemotherapy. Answer D, which is adult trastuzumab emtansine, is also incorrect because there's a Gatsby study that showed that it did not improve survival over taxane chemotherapy. And finally, answer E, lapatinib is incorrect because multiple phase 2 studies have shown lack of benefit for lapatinib as an agent in gastric cancer. So in this situation, you for this question specifically, you kind of have to know the results of the Destiny Gastric 01 study. The next question. So a 72-year-old woman presents with abdominal pain. The CT shows a cecal mass without any other evidence of metastatic disease, and there was no evidence of bowel obstruction. She underwent a right hemicolectomy, which revealed a PT3N0 moderately differentiated adenocarcinoma. 0 out of 13 lymph nodes were involved. The tumor had lymphovascular invasion, but no perineal invasion. There was no perforation. Immunohistochemistry revealed intact expression of MLH1, MSH2, and PMS2, but absent expression of MSH6. Which of the following is the most appropriate management? Is it A, adjuvant 5-FU and leucovorin for 6 months? B, adjuvant capecitabine and oxaliplatin for 3 months? C, adjuvant FOLFOX for 6 months? D, adjuvant pembrolizumab? Or E, active surveillance? So what is this question trying to ask? So this patient has a stage 2 colon cancer that's been resected. There are some high-risk features, so lymphovascular invasion. And then importantly, if you look at the mismatch repair deficiency testing, this is a mismatch repair deficient tumor, MMR deficient. So how would you do for adjuvant therapy for MMR deficient stage 2 colon cancer? So the correct answer is active surveillance, E. So these patients with stage 2 deficient MMR colon cancer do not benefit from adjuvant 5-FU leucovorin therapy. And in fact, studies have shown that giving them adjuvant 5-FU leucovorin actually decreases their survival. So they should not get any adjuvant therapy. So answer A, adjuvant 5-FU leucovorin is incorrect because for the reason that we just discussed. Answer B is CAPE-OX for 3 months. This would be appropriate for patients with mismatch repair proficient tumors, especially for high-risk stage 2 disease based on results of the IDEA studies, but this is not appropriate for deficient MMR tumors in a stage 2 setting. Answer C, FOLFOX for 6 months is also incorrect. So overall, for the stage 2 population for adjuvant therapy, oxaliplatin adds very little additional benefit to 5-FU leucovorin. And so it's perhaps best reserved for patients with stage 2 proficient MMR disease who have PT4B disease or multiple high-risk features. But for a stage 2 deficient MMR tumor, oxaliplatin-based chemo with FOLFOX for 6 months will not be appropriate. And finally, answer D, adjuvant pembrolizumab is incorrect. There is currently no established role for adjuvant immunotherapy for stage 2 colon cancer. So next question. So a 57-year-old man presents with abdominal pain, hematochezia, and weight loss. So he is able to pass stool. CT reviewed a descending colon mass, multiple liver lesions, abdominal lymphadenopathy, and multiple lung lesions. A biopsy of the liver lesion showed metastatic adenocarcinoma consistent with colorectal primary. Molecular testing revealed KRAS wild type, NRAS wild type, BRAS wild type, HER2 non-amplified, and microsatellite stable tumor. Which of the following is the best initial systemic therapy regimen? A, FOLFOX plus bevacizumab. B, FOLFOX plus panitumumab. C, FOLFIRI alone. D, FOLFIRI plus ramucirumab. Or E, trifluridine tipiracil plus bevacizumab. So what is this question trying to ask? So this patient has a left-sided colon cancer that is pan-RAS wild type and microsatellite stable. So what is the best first-line regimen for this setting? So the answer is B, FOLFOX plus panitumumab. So there's multiple studies, including the paradigm studies, that have suggested that for left-sided colon cancer that are RAS and RAF wild type and MSS, that using an EGFR inhibitor when added to the chemo backbone is better than using a VEGF inhibitor when added to the chemo backbone. So that's why FOLFOX plus panitumumab is preferred over FOLFOX over bevacizumab, which is answer choice A. So this is for left-sided RAS wild type MSS colon cancer. So answer choice C, which is FOLFIRI alone, is not correct because multiple studies have shown that when you add a biologic to the chemo backbone for first-line chemo for colorectal cancers, you can improve survival. Answer choice D, FOLFIRI plus ramucirumab, is incorrect because ramucirumab is a VEGF inhibitor. So ramucirumab is actually approved with FOLFIRI for second-line therapy following progression on first-line therapy. And finally, answer choice E, trifluridine tipiracil with bevacizumab is incorrect. So trifluridine is also known as Lonsurf. So this is a regimen that is approved for refractory colon cancer, meaning third line and beyond setting. So not for first-line therapy. Next question. So a 72-year-old woman has been diagnosed with metastatic cecal adenocarcinoma. Molecular testing reveals KRAS wild type, NRAS wild type, BRAF V600E mutation, HER2 non-amplified, and microsatellite stable tumor. She began first-line systemic therapy with FOLFOX and bevacizumab. 4 months later, her CT shows new liver lesion and peritoneal carcinomatosis consistent with disease progression. Which of the following is the most appropriate next line of therapy? Is it A, FOLFIRI plus cetuximab, B, binimetinib plus encorafenib plus cetuximab, C, encorafenib plus cetuximab, D, dabrafenib plus trametinib, or E, vemurafenib? So this is a metastatic right-sided colon cancer patient whose tumor has a BRAF V600E mutation. So this is a special category of colon cancer. So it's asking if we know what to do for second-line therapy. Do we continue with the standard FOLFIRI and cetuximab therapy like we do for other colon cancers? Or do we use BRAF and MEK targeted therapy? And if so, what's the right regimen? So the correct answer is C, encorafenib plus cetuximab. So to know this, you have to know about a study called the Beacon study. So the Beacon study led to the approval of encorafenib and cetuximab as second-line and beyond therapy for metastatic colon cancer patients harboring a BRAF V600E mutation. So answer choice A, for FOLFIRI plus cetuximab, is incorrect because this was the control group in the Beacon study, which showed that encorafenib and cetuximab improved survival over FOLFIRI and cetuximab, or irinotecan and cetuximab. Answer choice B, which is binimetinib plus encorafenib plus cetuximab, is also incorrect. So the Beacon study showed comparable efficacy between the triplet therapy of bini plus encorafenib plus cetuximab and the doublet therapy of encorafenib plus cetuximab. And therefore, when the FDA approved, the regimen they chose was encorafenib plus cetuximab, the doublet regimen. Answer choice D is dabrafenib and trametinib. So this is also incorrect. So although this regimen has a tumor agnostic approval for any advanced solid tumor harboring a BRAF V600 mutation, there is an exception, and that's the case of colon cancer. So because this regimen doesn't work in colon cancer with BRAF V600E mutation. And finally, answer choice E, which is vemurafenib, is incorrect because single-agent BRAF inhibitors do not have activity in metastatic BRAF V600A mutant colon cancer. Next question. So a 59-year-old man was recently diagnosed with metastatic cecal adenocarcinoma. Molecular testing revealed KRAS G12C mutation, KRAS wild type, BRAF wild type, HER2 non-amplified, and microsatellite unstable tumor. Which of the following is the most appropriate initial treatment option? Is it A, FOLFOX plus bevacizumab, B, FOLFIRI plus cetuximab, C, FOLFOX plus nivolumab, D, pembrolizumab, and E, adagrasib. So this question is asking about what to do with the MSI-high metastatic colon cancer that also harbors a KRAS G12C mutation. So choice E, adagrasib, is a specific KRAS G12C inhibitor. So do you do the standard chemotherapy like in other types of colon cancer? Do you do chemo plus immunotherapy like choice C? Do you do immunotherapy alone, which is choice D? Or do you do the KRAS G12C inhibitor, which is choice E? The correct answer is choice D, pembrolizumab. So pembrolizumab was shown in the Keynote 177 study to lead to a significant improvement in progression-free survival compared to standard chemotherapy in the first-line setting for MSI-high metastatic colon cancer. So this is an FDA-approved regimen. So that's why in the first-line setting for metastatic colon cancer, if the tumor is MSI-high, you would choose single-agent pembrolizumab versus standard chemo. And that's also why choices A and B are incorrect. And of note, FOLFIRI plus cetuximab, so cetuximab would not have activity for KRAS mutant tumors anyway. So answer choice C, which is FOLFOX plus nivolumab, is incorrect because we currently do not have any data yet that we need to combine chemo plus immunotherapy for MSI-high metastatic colon cancer. And finally, answer choice D, adagrasib, which is a specific KRAS G12C inhibitor, is also incorrect because this is an investigational agent that is being investigated for KRAS G12C colon cancer, but we still need more mature data to confirm how well this drug actually works, and it's not actually an FDA-approved treatment. So in this case, the MSI-high status trumps the KRAS G12C mutation status. So next question, a 41-year-old man who is a known BRCA2 mutation carrier presents with jaundice and unintentional weight loss. Imaging revealed a 4.2 centimeter pancreatic head mass with no celiac axis involvement, 360-degree superior mesenteric artery involvement, and less than 180-degree contact with the superior mesenteric vein and portal vein confluence. There was no definitive evidence of distant metastatic disease. So after biliary decompression and normalization of bilirubin, which of the following is the most appropriate step in management? Is it A, surgical resection followed by adjuvant FOLFIRINOX, B, systemic therapy with FOLFIRINOX, C, systemic therapy with gemcitabine, D, external beam radiation alone, or E, olaparib? So this question is trying to ask you to recognize that this is a locally advanced pancreatic adenocarcinoma. So the key is that if there's a 360-degree involvement of the superior mesenteric artery, that is a locally advanced pancreatic adenocarcinoma, so that patient is not resectable, and therefore that eliminates A. And so the correct answer is B, FOLFIRINOX. So due to greater than 180-degree involvement of the SMA, the patient has locally advanced unresectable pancreatic cancer, and therefore FOLFIRINOX is the most appropriate systemic therapy because it has been shown to improve survival over single-agent gemcitabine. So answer choice A is incorrect because this patient's tumor is not resectable. Answer choice C, gemcitabine, is incorrect because FOLFIRINOX improves survival over gemcitabine. Answer choice D, which is external beam radiation, is also incorrect because external beam radiation is generally used for palliation. The patient has no pain, and therefore systemic therapy is most appropriate. Chemoradiation has a role in locally advanced pancreatic cancer in that it provides local control, but it does not prolong survival. But it is something that we use in our treatment modality for locally advanced pancreatic cancer, usually after a period of systemic therapy. And finally, answer choice E, olaparib, is not correct because olaparib is approved as a maintenance therapy after first-line platinum-based chemotherapy for patients who have germline BRCA mutation, but it's not used as first-line therapy itself. So this is kind of a distractor answer choice. I think that's all the time we have. We're at 6:30 Central Time. Thank you all again for joining us, and I wish you good luck on your test and on your for preparation. Thank you.